Hello. This is the ARD study note. This note is Supplemental Oxygen Therapy Part 1, covering its definition, general goal indications, contraindications, and the definitions and differences between low-flow and high-flow systems. In the ICU emergency room and wards, whom are we treating? And, for what are we doing so? It is no exaggeration to say that we are primarily working to help patients who are in breathing to breathe better. One of the key purposes of breathing is to maintain oxygenation. Many diseases pose challenges to maintaining oxygenation. In such cases, patients are admitted to the hospital and receive treatment through surgery, medications, and injections. However, if appropriate oxygen saturation is not maintained during this process, all efforts can be rendered futile. Thus, maintaining oxygenation is the foundation of all medical and surgical treatments. When there is a problem with oxygenation, equipment or devices used to support it include nasal cannula, oxygen mask, Venturi mask, high-flow nasal cannula, non-invasive positive pressure ventilation, mechanical ventilation, and in severe cases, extracorporeal membrane oxygenation may need to be performed. Supplemental oxygen therapy is the process of supporting oxygen using relatively simple tools, like the nasal cannula, oxygen mask, Venturi mask, and high-flow nasal cannula. The primary general goal of supplemental oxygen therapy is to minimize the workload on the cardiopulmonary system by maintaining appropriate tissue oxygenation. According to the Clinical Practice Guideline of the American Association for Respiratory Care, revised and updated in 2002, supplemental oxygen therapy is recommended in cases of documented hypoxemia where PaO2 is less than 60 millimeters of mercury, or SaO2 is less than 90% in individuals breathing room air, and PaO2 or SaO2 below the desired range for a specific clinical situation. It's also recommended for acute care situations, in which hypoxemia is suspected, severe trauma, acute MI, short-term therapy in the recovery period after anesthesia, and surgical interventions like hip surgery. If there's a situation that calls for supplemental oxygen therapy, there are no specific contraindications that should outright prohibit oxygen therapy. Clinically, there are far more cases of death due to hypoxia from providing too little oxygen, whereas cases of complications from providing too much oxygen are rare. While complications from oxygen do exist, in reality, they are not common enough to be a problem in clinical settings. For supplemental oxygen therapy to be effective, it needs to be delivered through the airway from the oxygen source to the lungs. In this process, oxygen supply systems or devices play crucial roles, and a proper understanding of these is essential to perform supplemental oxygen therapy effectively. The oxygen supply system can be divided into low-flow systems and high-flow systems. Here is a question. Low-flow systems provide low FiO2, and high-flow systems provide high FiO2. Is that correct? A simple oxygen mask, one of the devices of a low-flow system, and a Venturi mask, a device of a high-flow system that is less frequently used nowadays, are examples. The FiO2 range that each device can provide is 40 to 60% for the simple oxygen mask, and 24 to 40% for the Venturi mask. This means that the simple oxygen mask, a low-flow system, can provide a higher FiO2 than the Venturi mask, a high-flow system. Therefore, it is not correct to say that low-flow systems provide low FiO2, and high-flow systems provide high FiO2. So, what's the difference between low-flow and high-flow systems? To distinguish between them, it is necessary to understand minute volume and peak inspiratory flow. In respiratory physiology, the minute volume, which is the ventilation volume per minute, is about 5 to 10 liters at rest in healthy adults. In other words, Normal persons inhale and exhale 5 to 10 liters per minute. In a disease state, the sustainable minute volume can increase up to 20 liters. At this time, the peak inspiratory flow, which is the maximum speed of the flow that forms in the airway to inspire the necessary minute volume, is faster than 3 times the minute volume, exceeding 15 to 30 liters per minute, or even 60 liters per minute in patients. The reason it exceeds 3 times is as follows. In a normal breathing cycle, the ratio of inspiration to expiration time is about 1 to 2. The maximum flow rate formed during inspiration is the peak inspiratory flow, and the maximum flow rate formed during expiration is the peak expiratory flow. If the respiratory rate per minute is 20 times, one respiratory cycle lasts 3 seconds, of which the inspiration time is 1 second, and the expiration time is 2 seconds. Therefore, the total inspiration time in 1 minute is 20 seconds, or 1/3 of a minute, and the total expiration time is 40 seconds, or 2/3 of a minute. Furthermore, if the minute volume is 5 liters, then 5 liters should be inspired in 1/3 of a minute, and 5 liters should be expired in 2/3 of a minute. To inspire 5 liters within 1/3 of a minute, it is necessary to maintain a flow rate of 15 liters per minute. This rate is arrived at by multiplying 5 liters by 3, the reciprocal of 1/3. And this flow rate is sustained during the 20 seconds of inspiration time. On the other hand, to expire 5 liters within 2/3 of a minute, a flow rate of 7.5 liters per minute must be maintained. This rate is achieved by multiplying 5 liters by 1.5, the reciprocal of 2/3. And this flow rate is sustained over the 40 seconds of expiration time. In other words, as shown in this figure, the flow during inspiration and expiration must be maintained equally. However, actual breathing doesn't work this way. In the phases of inspiration and expiration, the initial flow is slow, and as time progresses, the flow increases until it reaches peak inspiratory or expiratory flow, then slows down in the later stages. Therefore, in the early and late stages of inspiration and expiration, the flow is slow, and only a very small part of the minute volume can be inspired or expired. Therefore, the flow around the time when the peak inspiratory and expiratory flows form must be sufficiently fast to breathe the set minute volume in the limited time. Consequently, the peak inspiratory flow must exceed 3 times the minute volume, and the peak expiratory flow must exceed 1.5 times the minute volume. This is why the peak inspiratory flow exceeds 3 times the minute volume. The low-flow system is a system where the device supports a part of the peak inspiratory flow formed in the patient, typically supplying less than 6 to 8 liters per minute. On the other hand, the high-flow system is a system where the device supports oxygen with a flow rate much higher than the patient's peak inspiratory flow, typically supplying more than 40 liters per minute. To sum up and compare, low-flow and high-flow systems have these differences. Let's look at specific examples of representative devices from each system. Here's a relatively stable patient with a nasal cannula, a device of the low-flow system. If this patient's minute volume is 5 liters, the peak inspiratory flow is faster than 15 liters per minute. In this situation, if 100% oxygen is supplied at a flow of 5 liters per minute through the nasal cannula, 5 liters per minute of the total peak inspiratory flow is supplied by the device, and the remaining flow of more than 10 liters per minute must be inhaled by the patient from the room air. Thus, the low-flow system is a system in which part of the peak inspiratory flow is supplied by the device's flow, and the patient must self-inspire the remainder of the flow. In the same patient, a Venturi mask, a high-flow system device, is applied. The Venturi mask is a device that can supply a high flow by mixing 100% oxygen and room air. It will be discussed in greater detail in Part 2. If the total mixed gas flow is set to 45 liters per minute, it exceeds the patient's required flow of 15 liters per minute. However, since the device provides a much larger flow of 45 liters per minute, the patient doesn't need to inspire additional room air. In other words, the high-flow system is a system that supplies the entire peak inspiratory flow, eliminating the need for the patient to inspire additional room air. This concludes the definitions and differences between low-flow and high-flow systems. So far, in Part 1 of Supplemental Oxygen Therapy, I've explained the definition, general goal, indications, and contraindications of supplemental oxygen therapy, as well as the definitions and differences between low-flow and high-flow systems. Thanks for your listening.